TSG status report number 2, and you also have TSG status report appendix. And then that is what your slideshow and presentation is referenced to. You all should have got that in the mail yesterday, and hopefully have had a chance to read it at least 3 times. So it's all there for you.
And you know, there'll be plenty of time for questions too if you have any. Obviously, Mr. Chairman will be here today just to introduce my members of the team that are here today. Richard Kellogg, unfortunately, can't be here for these 2 hearings. He had another matter he had to attend to, but he's helped immensely in terms of the report, and he's been with me every week in Arkansas, and we've really been meeting with a lot of great people here. With me is Stephen Palmer. Stephen Palmer, and I think I've said before, Stephen is our Medicaid policy expert, was Governor Perry's healthcare expert for a number of years. Rory Rickard is going to be talking today about pharmacy. Rory's our pharmacy consultant expert. He's here. Rory, can you just stand if you can in the back? And then Bob Shin is here. Bob will be talking more on the payment improvement issues tomorrow. He also is an expert in DRG and other hospital methodology for reimbursement. So there's some questions that come up there. Bob will be here to address that. And also Martha will be here tomorrow for the hearing. Jason Melanson, looking at the eligibility system, will be here as well. So we're going to go real quick. I'm going to go as quick as possible. I want to make sure that you have time to absorb this, but Phil has done a great job making copies and getting everyone copies. So the first thing I want to let you know, the carriers in the department have provided us with all the claims that we need in the data files. We want to thank VLR for their work in helping us set up a real large data warehouse here within the VLR system. So now VLR can have the data too and work with it even beyond our time here working with you. We also have secured a VPN, and everything's within the firewall, so there's no HIPAA issues at all. And our team's working at that computer site now, even as I speak, on analyzing some of the data. You're not going to see any of that analysis today because we're still going through a lot of data cleansing issues that some of you may understand when you get such a massive amount of data. So there are some issues, and I want to make sure I'm not bringing to your attention like real concerns that we need your help with, but there are a number of ID issues. There's different year dates. There's areas where years are 9999. Obviously can't be a termination here. We have to go back and ask a lot of questions from these experts at Blue Cross, Qual Choice, and Ambetter, and they've been very helpful. And yesterday the Medicaid ID numbers from Blue Cross were fixed. So again, these are all high-level issues that I don't want to bother your time with, but to just let you know, we are on schedule. And hopefully by the August update, you will see some real good, instructive data analysis. And like I said, we're in the process of clearing these issues up. The expectations, and you know, if you think that there's other areas within our scope that we should be looking at, a lot of you have sent through the chairman questions. I have your original questions. We've tried to address most of them. There's still some outstanding that we're going to leave for our final report, but we are aware of all of them. We really value their opinions. We want to look at the premium-based private option population by age, county, level of claim. We want to compare carrier claims to premiums to understand the experience. We want to also look at the frequency of claim by beneficiary. We're going to be able to see a lot of different patterns that will be unique. And there's some patterns that we feel that are really important to our, obviously to our analysis, but really important to certain questions that you've already asked. We're going to be looking at claims across providers to consider adverse trends in utilization. And we're going to also, we have a tool that we use, and we've also trained, so we're going to be training workforce, your department workforce on the use of that tool, because they're going to help us with some of the work data, which I'll talk about. We also are going to be working with making sure that VLR, when this is all done, will understand and be able to use the tool that we have and really be able to work with the data for you in the future. So that's a value add that we're bringing to the table. I want to start here with the Healthcare Defense Program, and this is really Senator Bledsoe's issues from the last on the medically frail and My goal here is the next couple slides to really get you to understand the medically frail issues, the PMPMs. What is going on in terms of claims experience right now? But what I did is I put together a process map because it was very difficult for me to try to understand at a high level. Okay, how does someone become, get into the fee-for-service system versus the private option? We're going to call private options, another term could be newly eligible. But when we start talking about the health independence program, it involves medically frail. But they're paid for 100% of federal dollars now, but they're in the traditional Medicaid program because that's required by federal law, which is in our appendix in our report, the law. So you'll see where when you fill out the questionnaire, there's really two areas that you're going to go down. You're either going to go down these two paths, medically frail, or you're going to go down the path of not frail. If you look at the numbers, 243,615 claim or beneficiaries, that was third quarter 2015. When you look at the medically frail, you're talking about somewhere over 25, close to 25,000 right now. So the not frail is your vast majority. If you're medically frail, you have two paths. You can go to the traditional fee-for-service, which is 22,629 right now, and the alternative benefit plan. Many are not taking the alternative benefit plan because the fee-for-service has a lot of other long-term care and certain benefit structure that is not available in the alternative plan. What I want you to do here is to look at, we are now starting to formulate, and we're going to be formulating for you, maybe, let's think of it as a cost-benefit analysis. What's going to happen if the private option were to go away? What would happen if you were to continue it? How much would it cost down the road? We're going to do all that modeling for you. What I want you to see here is questions that I asked the staff, because I have had the privilege to negotiate waivers. And I think I've said to some of the staff here that I thought the State Department of Human Services did a really good job on the negotiation of this waiver. This waiver was negotiated to your benefit in terms of the value that was brought over from your fee-for-service program into 100% payment right now. And that will change down the road. What we call that is cost not otherwise matched. Areas where you're paying general fund and now you're getting a federal match to cover more of the general fund dollars. I just want to show you the significance of this. Family planning, 1.6 million. Tuberculosis, small amount, but important program. Breast and cervical cancer, these are programs on the left side. 4.3 million for fiscal year. These are general fund dollars. Arkansas Health Networks. This is your catastrophic plan that went away. All subsumed within the newly eligible health independence program. Then you look at the categories. The medically needy at 6.6 million, many of those are covered under your normal age, blind, and disabled Medicaid fee-for-service population. Those are now covered under the newly eligible. Aid to age blind, same thing. Pregnant women. It's very important for you to understand when you decide the policy questions here that $19.6 million are women that come onto the private option that become pregnant post-eligibility. And they would normally be covered, because Medicaid has to cover the pregnancy up to 60 days after the delivery. And that's covered under your traditional Medicaid. Your 30% cost is now all shifted to federal government, covering over today 100%, but as you go, it'll be a little more. But these are costs that have been shifted to the newly eligible population. I just think it's important for this committee to know this as we begin to model what the impact will be going forward.
And when you say the cost, you're talking about, for instance, on that 19.6 million, to move that back to the traditional Medicaid would cost the state 30% of that because of the match.
That's the general fund component, 19.6 million.
That is the general fund.
That's
So
the
the
general
actual
fund.
cost is 3 times that.
Actual cost, correct.
Okay.
If you look at the budget, the actual cost is 3 times.
So all of these are already taking into account. This
They
is
match.
the state portion.
Correct.
So again, I'm always in the slow learner club. So are you saying that the $40 or $45 million that you have on this slide, if you add up those 7 boxes, 40 million or so, that's money that the state general revenue treasury has that we would not otherwise have. In other words, we're 40
Correct.
million to the good on this,
Correct.
that would go away
Correct.
instantly.
Or you could decide on some of them not to, you can decide, I believe, on Arkansas Health Networks not to cover that. You could decide not to go
I
forward.
understand we can make lots and lots of choices, but
Right.
given the choices we made,
Right.
whether we knew what we were doing, or we slipped into it, or stumbled down the stairs, or however we got there, we are 40 million to the good versus having not done it, just with this thing here.
Correct. This slide is more, again, this helps, I think Senator Bledsoe's question. I wanted to make sure we were able to drill down on, to give you an idea of what the PMPM is in the private option. We're getting to that point. We met with the state on a number of occasions the past few weeks to try to understand, and then also ask them continuously to give us back some information data, because they weren't including things like supplemental payments to hospitals. They weren't including a lot. And when we say this is a PMPM average, I want to make sure the committee gets really the real true per member per month cost. When I say true, the one that is including supplemental payments. So I think that's important, because these hospitals get payments at the end that are really for that population. So I asked them to allocate that. And so this is just one slide that lets you see the quarterly, these are quarterly payments. You see the number of eligible, you see the number of private PMPM, traditional, and newly eligible population at the end. These are quarterly PMPM. Again, this is on a point in time, and it's not per member month, so the PMPM is going to be a little more. What I want you to do is focus on this next slide. I don't, unfortunately, for some reason, on the left column, those are claim areas, categories, outpatient, inpatient, prescription drug, for these EPSTD, for these high costs. I will get you those categories. I'll get the actual spreadsheet. This spreadsheet was very large. To get it on this one PowerPoint slide is difficult. I want you to focus on the last three columns. This is calendar year 2014 medically frail. You will see, if you look at the calendar year medically frail costs, 134.6 million for 2014 calendar year comes out to about a PMPM $526 for the medically frail for calendar year 2014. We do have calendar, the current quarter, third quarter numbers, but they're not on a per member per month basis. They're on a static in time. But what you have here is now the supplemental payments kick in. All right, tell me the percentage of supplemental payments that are attributed to this population. And that analysis has been done, and it's an additional $138, which gets you to a PMPM for the medically frail, just about $664 for that calendar year 2014. You start looking at the last column, which is 2014-12, which is the December month. That would be the third column over. Those claim numbers are not that far off. They're not growing at a real high level, but they're a little higher now. So you might be somewhere around $700. And I'm throwing that out as an estimate because we're still drilling to make sure we get the right numbers here.
When we determine a cost that we provide the federal government to see whether or not we've exceeded the cap,
Yes.
are they including the supplemental estimate in that calculation?
I'm not sure of that. Director Seeley would have to answer that. And I would think they aren't, but.
Mr. Chairman, the medically frail costs are not inside the demonstration.
Why don't you come on up, because I think this is a fairly significant issue about
John Seeley, Director of the Department of Human Services. With me is Suzanne Bierman, who leads our payment improvement, our private option work and expansion work for the department. What I was explaining from back there is the medically frail costs are not in the demonstration waiver. The demonstration is for those in the private market are they in effect more expensive than they would be if we served them in the regular Medicaid program? Since the medically frail are in the regular Medicaid program, they're not part of that, $480 a month, if that's the question.
That is the question. I just didn't want to find out that the feds were going to come back and say, we haven't included this supplemental estimate in your calculation and you're really overcap.
No, we report it, but we always report it separately because that's not part of the demonstration.
And that's why there is a very strong incentive on the part of DHS to get the medically frail out of the demonstration population and into traditional Medicaid.
I don't know if I've never thought of terms of strong incentive because we simply have them take this screener and that determines whether they go in or not. We don't actually make a decision on any individuals per se and say, you're in, you're out, kind of based on your costs. So it may work out that way, but certainly the intent of the screener is to say if you've got more complex needs, we can be better served in Medicaid. That's when we put you in Medicaid grant.
Okay. Yeah, Representative Curry reckons.
Thank you. Looking at this on the medically frail, this is the 25,000 people on this. This is the numbers for the 25,000 people. We're paying basically costing us $664 a month for this population. What is the cost per month? You tell me on the traditional Medicaid system that we are having now, excluding this population.
That is an analysis we're still working on because it's very difficult because there's different Medicaid aid categories. And we're trying to get that down to the level of each category. So that's something we'll be reporting, Representative, hopefully at the next meeting. They've given us the initial numbers, but we're trying to drill down more.
To me, and I think we've given numbers a year or so ago, it's $1,100 a month. To this population, doesn't seem like this cost is medically frail. I mean, that's not, in comparison of the traditional Medicaid system that we were given a couple of years ago, that cost per month is probably half.
Yeah, it depends on what you're looking at again, because if you're looking at the elder, long-term care, it's a little different. Could be $1,400. Disabled could be, $1,800. Children are somewhere around $150. The last numbers I looked at. So I want to make sure we get this right for you and give you the best estimate. So the best amount real time. But when you say 1,000, you're looking at again more of the high cost utilizers.
So that's what we have. We broke down.
Yes.
Long-term care, hospital.
Absolutely. That's my plan to have that.
Okay, then that'll be this.
Yep.
Okay, thank you.
Mr. Chairman, just a question. I know a lot of this we're going to cover in detail tomorrow. I guess the question is, do you want us to stay up here, which might lead to more questions? We're happy to go to the audience for now. But
No, I think that, again, we're going to try not to chase any rabbits as we go through here.
So the next slide, this is an interesting slide. I want you to pay attention if you can when not now, later in the appendix. We asked a number of questions for the high utilizers. I thought the chairman's request for the top 100 utilizers was excellent. We got that data and information. We then they began to look at it closely with the department and their vendor that works on these issues. What we thought would be much more instructive because the top 100 is a lot of young children, NICU babies, premature babies, and other issues. We wanted to see the top 1,000. We got that data. And what we got for you is diagnosis level down to a lot of information, and it's in the appendix. So I'm going to go through this really at a high level, because this is going to help you frame your decisions down the road on how you want to handle some of these areas going forward as far as solution, because we want you to start focusing a little or more on these high cost cases. So you have, out of the high cost, mostly all are traditional Medicaid, 10 medically frail. A lot of newborns, hemophiliac. When you start looking at the top 1,000, behavioral health jumps out. A lot of mental health costs. You also see a number of the inpatient costs. Children's Hospital, $109 million, out of a total of $322 million. Now, I'll note for the record that Children's Hospital has a reimbursement structure that's cost-based. That's something you may want to look at, and we're gonna talk more about that. But that's a pretty heavy lump. They do a good service, quality service. We're going to be meeting with them in the next few weeks. Then we had a physician survey. It's all in the appendix, the answers. I want to recognize the fact that the physician community, the medical society, the Family Practitioners Association, and also the Hospital Association were so helpful. As soon as we sent our survey through SurveyMonkey with our key questions, they immediately sent it to the community, over 3,000 or so physicians and hospital executives. The response rate is not that high, but in that community, sometimes with doctors being so busy, and Senator Irvin probably knows as well as anyone, you're not going to get as high response. But that means that the results may not be statistically significant, but we thought it's significant enough to share with you, because there is an overriding theme, I think, and it comes into the issue of episode. And it's that the reaction is mixed. Even out of the 254, very mixed reaction. Is it saving money? Very mixed. Do you like it? Very mixed. And we saw that in the community as well. And interesting, I thought this was another real high level but interesting point, was about 90% said they treat Medicaid. And 84 or so % said they've been treating Medicaid before 2014. So I think you have a good structure in place, that there are physicians that are there willing to do a good job to help the Medicaid population. That was instructive to us. But again, statistically insignificant in the sense of a real survey. Yes?
Senator Sessions, you have a question?
Yes, just briefly, back on page 11, John.
Okay.
As we look at the cost, or as we look at the cost of children's health care, are we on average for what we pay, or are we above or below? Where are we?
You're higher at this particular facility than some of the other facilities. We are, for the next meeting, going to come back to you to tell you what other children's hospitals' methodology is in other states. So you will have, Senator, at least an idea. Are you different? Are you an outlier as opposed to other states?
That will be helpful. Thank you, Mr. Chair.
And before you leave the survey, as I looked at the results, and again, I was surprised that there were not more frustration voiced in the surveys based on the feedback that I've got with regard to these programs. How do you explain that?
Stephen was responsible for really analyzing the survey, so I'm going to ask him to answer that question.
Certainly.
Great question.
Senator, members, my name is Stephen Palmer. I'm a senior consultant with the Stephen Group. There was very strong opinions asserted. We had a number of pretext fields within the survey, and the negative responses were very negative.
Probably can't share some of those, huh?
I don't think there was any inappropriate language, but very strong feelings, certainly. And when John says that the results were mixed, when we asked questions like, how do you tell us whether you strongly agree, neutral, disagree, or strongly disagree with certain statements, like you believe that the episode program can save money, you believe that it improves quality, things like this. We would have something like 15 to 20% of the respondents in the strongly agree or agree category, 15 to 25% in the disagree or strongly disagree, and a decent sized chunk right in the middle. So that's the mixed part, is that we just sort of saw responses all along that continuum. But there certainly were on almost all of the questions that had that form, a pretty strong plurality on both ends of the spectrum.
Yeah, I guess, again, I was expecting a more slanted view one way, and apparently you got both extremes, but you also got a lot of people who either don't know or didn't have strong feelings.
No,
We got a couple questions here. Representative Brown, go ahead.
While we're on the survey, I just wanted to add, one of the survey bullet points is that you've got payment cuts, significant Medicare payment cuts that may overshadow new revenue from private option. Could you just give a little texture for what that was about?
That's the next slide, not the survey. So I'll get to that.
All right, I'm sorry, I'll wait.
Yeah.
Representative Farrar.
Thank you. On the survey results, are you going to give us the demographic breakdown of the rural hospital physicians, acute care
Yes.
hospitals?
It's gonna be in our final report. Also, so that you know, it's still available for physicians in the state. So, you know, if you know some physicians, we have the link. I'll make sure Phil gets the link and he can put it on the VLR website too.
Right, well, even different types of hospitals and reimbursements, different way hospitals are reimbursed makes a difference in this also. Critical care access hospital would be different
Understand.
than acute care hospital.
Yes,
You
Representative.
know, cross-based hospital like, children's, completely different answer than what I would use with my hospital. And I just like that, if you could, if that's what you do for me.
Yes.
Okay, Senator Sanders, you're recognized.
Yeah, I would add too, that when you look at that number in terms of the respondents, knowing which ones are primary care, which ones are specialty, we've got a couple instances where primary care providers are actively referring their patients to specialists who are delivering more value or, a lower cost. And so that maybe some of that residual kickback as well. I've talked to some practitioners who've gotten calls from their friends who are specialists and complaining about them not referring to them anymore, and the response is, you're too high and your quality isn't any better. So I think having that type of differentiation could help too in terms of the breakout of who those practitioners are.
And we will have that, Senator.
Okay, Representative Murdoch, you're recognized.
Thank you, Chairman. I guess along the same line of the two previous members, the 10% response rate, what are you doing to try to up that response so we have a good cross-section representation of the feelings of those that we're trying to interface with? Because sometimes when it happens locally, and I'm talking to you offline about this a little bit about access and local interventions, even with doctors, physicians, so many times when they get surveys, they're busy trying to serve, and they just kind of move that paper. So there may be some other ideas of local intervention where we can make sure we get a good response from all the people that are, so to make this city.
I welcome your thoughts, and maybe through the task force chair, you could give us some ideas. We did the best we can in terms of who we reached out to, the folks that really kind of had the associations, and it's still a low response. 254 or so physicians, and it's not bad for that community, but yet we would love to have this at the end of our report, a real high response rate, because it took us a lot of time to come up with the critical questions that we thought you really need to know. So, Mr. Bledsoe, your thoughts, all these thoughts would be welcome. I mean, I think we can talk maybe offline on that. Mr. Chair, welcome any thoughts.
I'll again, demographics, we want to make sure we get every part of the state represented. I'll be able to give you some ideas on how to get that done, at least in part statewide.
I appreciate it.
That'd be good. Maybe our friends of the media will help get the word out that this is an important part of our data collection as a survey to get the physicians to respond so we can get good data. In fact, we got the Surgeon General next on the list here, Dr. Bledsoe. Thanks, Mr. Chairman. Looking at the survey, I just had a quick question to make sure I understand this, because I've been getting feedback about the patient-centered medical homes from a variety of physicians. And the next to last thing where it says 80% are familiar and then less than 40% are PCMH providers, is that of the total respondents or is that of the primary care doctors that were selected out of the survey?
That's of the total respondents. In the final analysis, we'll break that up.
Yeah, because that would be an important distinction, because if you have, half of the respondents are specialists who aren't necessarily involved in the PCMH, that would change the way we interpret this information. I think it's a really important question to ask going forward, because we are getting mixed messages from a lot of providers around the state. Okay, Senator Urban.
Thank you. I just want to say, back here in the session when I ran my bill, I had a signature list of 40 physicians, supporting my bill with doctor program. So those surveys, I'm personally, giving them to those doctors, and we can do that as legislators. You can go and talk to your constituents and say, here, we need you to fill out the survey and do it, give it to them. I think that's important, so I think your said responses are still coming in, and that will be part of your final report, is that correct?
That's correct, Senator. And also with regard to the media, there's a link that we have that we've sent to everyone. So all they have to do is go online, Survey Monkey that we use, and fill out the questions online, and immediately populates to our system. So that link we could give out to the media at the chairman's request as well.
Okay, one more, then we're gonna get on with the report here. We got a lot of stuff to cover. Representative Hammer.
Request of the chair, suggestion. I'd like to suggest that the chairs work with the Stevens Group, identify one doctor that has a very strong opinion, one way, a strong opinion the other way, include maybe a specialist, and bring a panel in and give us about an hour to talk to him, because I think that would give us all a chance to hear from those instead of having to filter that information through there. It's just a recommendation.
But we'll see how it goes tomorrow when we're addressing this topic, because we're gonna have representatives, I'm sure, who have strong feelings both ways on that. But it's a good idea, and if we don't get feedback tomorrow, we'll work on it. Okay.
So this one is provider feedback. So we actually went to the community, and Senator Irvin, thank you for the invite. And we're trying to get to as many places as we can to meet with really on the ground folks that practice. And the Mountain View place where we went and we heard from a very vocal group about certain issues, and we listened carefully. And these are some of the things, Representative Collins, that's where this came from. And there was a lot of concern about episodes. And there wasn't only just two, there was about 35 to 40 physicians and hospital executives, and very vocal people in the rural community that handle a lot of the community access issues as well, and very well thoughtful responses. Payment cuts, they were concerned about the Medicare cuts, and we talked about some of these issues because they do have an impact on your whole system and what you decide down the road. They're also feeling that with regard to the private option, they're seeing more insured individuals coming through the door. They're receiving more revenue due to the insured issues, obviously. There's an issue with the uncompensated care, fewer uninsured patients, less uncompensated care, is what they told us, the hospital executives. But the one thing I remember, and it's not on the slide, is also some of the emergency room doctors that I'd like to just say, they're treating individuals that are coming in that don't have insurance. And then they're getting access, but they don't know if they're going to get payment or not. And they're treating them, obviously, in a non-emergent situation. They're treating them and referring them to the primary, actually acting like their primary care within the emergency rooms, which I found very, very helpful and a way of making sure you minimize those costs going forward. They're educating them on inappropriate use of emergency room as well. And then where to sign up for insurance and what to do with regard to those access issues.
So John, my question on that is, so what are the ideas to reverse the significant Medicare payment cuts? And I get that they may be so severe that they overshadow the new revenue that we are getting, but did anybody have any idea, or is there any possibility, or is it humanly possible to reverse the significant Medicare payment cuts?
I mean, I don't have a way of answering that because that's more of a federal policy issue, Representative. I mean, it's a clear issue with these doctors and hospital executives as well. I mean, it has impacted your economy. It has impacted the community. The next one, and I want to be respectful of time, so I'm trying to go as quickly as possible. PCMH. So I'm going to really try to go quick here, but the PCMH program, the department has indicated to us that there's a lot, it's about 80% of the program, but it's not, we don't find that PCMH is where it could be even more helpful in the high-cost settings, the age, blind, and disabled. That's really a high note here. We're going to talk more about that as we go further in our, next month, more on long-term care. But just remember, PCMH may be a good program, but it's not really addressing the high-cost populations. Episodes of care. This is going to be discussed tomorrow on payment improvement. Stephen's done some financial analysis, worked closely with the department. bottom line takeaway here is, nobody has really looked at how much does this cost? And so we tried to dig and ask questions. Okay, every vendor that had any direct or indirect relationship here, you know, whether it's GDIT on the analysis, whether it's on the claims HP, including the McKinsey contract, how much were they involved in episodes versus PCMH, how much of their time spent, I mean, really digging here. And we're going to give you some ranges, and you're going to hear more tomorrow. So you'll be able to know, I think you'll have a good idea how much it's cost, and the department can give you its thoughts on whether it's saved money, and we'll tell you what we think. But I kind of want you to focus on that tomorrow, because this involves a lot of questions, if that's okay. Early findings, you know, our team, this is a very complex issue, by the way. And it's very thoughtfully designed and constructed. But I guess the key concern here is the time and cost of the development, expansion, implementation, operation, maintenance. The last point of the slide is something I want you to focus on as we continue to discuss this. Then we're going to talk about DRG payments. Bob Chin is here. He's going to be here tomorrow when we talk about payment improvement. So I want you to think about other ways, and the DRG payment methodology could very well be a way to get to where you need to be down the road in terms of innovation and improvements. So this is just, again, to give you some thoughts. If you're thinking about DRG, tomorrow Bob's going to be here, and I would ask him some of those questions. State Medicaid reform models. I think Chairman Hendren once asked, you know, what do other states have? We tried to drill down and look at, okay, which states have managed care, which have PCCM programs, which have ACO, which have the district, which is hospital-based, almost a collaborative community approach. We'll get you a little more information, obviously, on this as we go forward, but I just want to give you a high level, and it's in your appendix as well. And Senator Chesterfield, we did bring out the acronyms. We gave that to you, and hopefully all these acronyms you get, and if you don't know what they are, please ask me. I'm trying to do the best we can on that issue. This is important, I think, this slide. I want to spend just a minute on this. Okay, this is a 2012, I believe, Truman study, or Kaiser. No, 2013, I think, from Kaiser. So this is as recent as the data you're going to get to compare all states. What you have here, and Director Seeley and our team have come up with and evaluated and found, you know, identified that 2.2% growth here in Medicaid. You know, I'm being asked questions, is that low? How's it compared to other states? I want you all to see it right here. It is below the national average, but it's not the lowest. It's not among the lowest, but it is lower than the national average. But state Medicaid programs were not growing as much as they have been in the past few years between the time periods of 2010 and 13. And when you start looking at the lower ones, and that's what I want you to start looking at as well, what do they have? And also your surrounding states. Let's look at where Arkansas is compared to surrounding states. Tennessee, Louisiana, lower than 1% growth. Texas, 1.2 or 3% growth. The next one is, what are the lowest states in terms of during that same time period? And I know Senator Hendren had wanted us to focus on, okay, what's working in those states if they're low. This is a slide that's going to give you the states that are really low Medicaid states. And if you look at, you know, Arizona, New Hampshire, there's reasons for this. And I can tell you there's a lot to do with waivers, a lot to do with negotiations and legislative support, not just straight rate cuts or anything that's cutting programs, more quality, more coordination, and you'll start to see some of that. Rhode Island as well. Remember someone at the first meeting asked about Rhode Island on a waiver they had. They did a lot with long-term care. So we can talk about that as we get going. But I wanted you to just listen.
We've got a question here. Senator Sanders, you recognized for a question.
Yeah, John, if you would, I think the other part that would help is to provide on these states, particularly around us, provide some sort of framework for the basic coverages. As you know, and you guys are familiar with we have a lot of programs that other states don't have.
Absolutely.
So I think showing both the cost basis and the growth or the lack, negative growth, in concert with what they provide in terms of other benefits on top of that. Because we also have a ton of waivers. We just haven't used those waivers perhaps in a manner to drive down cost. But I think that would be helpful. Because I think there are some things, I think some of your recommendations that you'll bring back to us may even call for the elimination of some programs or changing programs. And I think to understand why that is, I think that would frame it up a little better.
I absolutely would. Our group is going to do that, and I think it's a really important thing for you. You know, in high level, you know, I could just, you know, Arizona, I know that managed care, very intensive. They've had managed care for a long time in the age blind, disabled, other areas. You know, in New Hampshire, it's a lot of rebalancing. Then you look at South Carolina with there were really low rates in some of the areas too. So you got to be careful. You have to look at the whole picture, and we're going to bring that back to you, so you get an idea and how does it compare to what your program is today, Senator. I'm going to pass over these inter-RI slides to the assessment. Richard Kellogg's not here today. This was his contribution. There's a whole section in your status report that Richard has put together with regard to assessments. Bottom line on the assessments is the next meeting, we're going to probably want to come in with a lot more detail for you and really understand, and I know that you're meeting with Craig Cloud, or one of the committees is meeting with him on the GoCentric issue, and to identify these assessments. And the big picture here is, all right, you're spending a lot of money on this assessment approach, but you're not bringing in behavioral health, and you're not bringing in all of long-term care in a unified, standardized way. And there's discussions going on, and we know the governor's office has put out an RFI, and there's discussions of an RFP for potential for managed care, whatever that means. Whether it's capitated, whether it's managed fee-for-service, it could be a lot of different models. In the traditional managed care model, they do the assessments in most of the states. You know, and the question we're going to have to figure out here is, what we don't want you to do is to be spending a lot of money in areas that's long-term not going to be beneficial to the taxpayers of the state. Is a unified, standardized assessment the right approach? And Mr. Kellogg puts that in the report, very well said, well written, and you should review that section. It is absolutely necessary for this state to really want to get to a rebalancing if you want to go in that direction. So there's 2 slides here on inter-RI, and if you have any specific questions, I can absolutely get those to Mr. Kellogg.
Just in general, how much we spent on that?
He has spent, in money-wise?
Yeah.
Representative Hammer, I believe, had a committee here with Mr. Cloud, somewhere around $9 million in this last year. It's in our appendix. But as far as to date, I don't know the numbers, but I think they're in our appendix. The representative may know better. We'll get that for you, though.
Representative Hammer, your recommendation.
Thank you, Mr. Chair, and I agree with the type figures, but if you calculate the original contract that this all started under, where the company went broke, that was about $4.57 million, and I think with the GoCentric contract right now, they're into it for about $10 million, and then we'll have to ask DHS as far as what they've spent, or if that number includes what's been paid out to actually get the assessments done out in the field. I don't have the answer to that question.
And we'll make sure, it's actually, those figures are in the status report that we've given in this area. So I just don't have them right off the top of my head. But around $9 million this year for GoCentric, I believe, is what I remember reading. At the end of the day, we just got to figure out this assessment approach, because that's going to drive your plan of care, it's also going to drive your right place, right time, right service, making sure you don't provide too much, not what's needed, and that you provide it in the right setting, at the right place and right time. Very important to get this one right. Case management. I think this is very instructive. If we looked at the other states, we found in our interviews with the department, there isn't a lot of effort put on care coordination and case management in the behavioral health and in the long-term care areas. And you look at, then we went to Truvin, where some of the national data to try to understand where are you compared to other states. And then you look at your expenditure per resident on case management. And this is a very telling slide, and it's one that Richard will be talking about in more detail, and we'll have this in our final recommendations, because you're going to see, you don't pay a lot for care coordination in this state. You don't pay a lot for case management. Now again, if you go down the road of a managed care or even a primary care case management into along the high-cost settings, whatever you do, you need to make sure you look at that whole care coordination, case management idea in option, because that's really going to keep a lot of the population from spending a lot of time in unnecessary locations, expenditures, and doing the right quality. But this is very instructive. Behavioral health, care coordination.
Before you leave that, Senator Sanders for a question.
Yeah, again, just to round out the analysis, I think it would, I mean, one of the things that would be helpful is if you could also discuss the plans of the initiatives that the department may have had sort of planned launch with regard to, you talked about the assessments and not being able to get that done. But I think you should look at all the different models, particularly for health homes that were supposed to be utilized for targeting the high utilizers, but look at what the department had planned and what they were able to, and sort of that whole joke, implementation and operational. But I would look at some of the things that they had planned and to try to provide members with maybe to try to gather the history on that, why it wasn't able to be implemented. This was put on hold. Legislature took action here. Something. I think that would be beneficial to round out. Sort of maybe we had plans, but weren't able to get to them. How about that?
Absolutely. In one of our either earlier report, we talked about how the department did attempt to move forward in high-cost settings, and we'll get the history. In our final report, we'll make sure we get all of that. It's not that they haven't tried.
I guess I would kind of like to record, I'm looking on page 23 and on page 20 where you've got the ones that have the lowest rate of growth, and then you have the ones here that have the highest spending on case management. To see what the correlation is. Are these states that are spending more having lower growth and lower cost per member per month?
Absolutely.
Okay, Senator Irvin, you're right.
Yeah, one thing I wanted to add to that is also utilizing our current structure that we already have versus contracting out. So I think that's something that it was discussed a lot in the meeting with the providers, a lot of brainstorming, a lot of ideas. How do you utilize a structure you already have in place? And I think I would like more thought on that as well as you go forward with as regards to case management. Because there was a lot of discussion about that, particularly in the area of mental health.
Well noted. The other thing, behavioral health, and this is an area where we definitely, have identified a need, a concern. You don't have a lot of care coordination in behavioral health, and the number of providers, the any willing provider law is an issue too, because there's not really a good amount of control over what they're spending in what we call RSPMI, your serious persistent mental illness for the residential services. And community health center, the community mental health centers, the providers are paid and the physicians are paid, and there's not a lot of coordination of that effort. And it's very costly in the budget. And we're comparing that to other states, and we're going to get you more information on this. Again, those are high-cost populations, and then we're seeing a lot of that showing up in the top 1,000 utilizers. And there is, in our opinion, and we'll give you more through evidence-based approaches, a correlation. And we feel that way in our group strongly. So it's something we want you to focus on. Again, PCMH model didn't make its way into behavioral health. Senator Sanders' point's well taken. We know the history there. We will be able to give you that in our report. Nursing facility eligibility. That's the next meeting. We talked to the chairman about long-term care issues. We're hoping to focus a lot on long-term care for the next meeting. And just want to give you just a high level, your nursing home eligibility, it's a 703 form. The level of care, we call it, and I have the form here. The level of care rules and form the rules are applied, and the level of care is determined by the nursing home nurse. The nursing home nurse. And then most of the folks that go into the nursing home settings will end up most likely staying there and being eligible. And when you look at the level of care, and I've worked in other states on level of care issues, and I've also shared this with other states to look at, it's broad compared to some of the other categories. And the department's nursing staff indicated to us that it's very broad in its interpretation as well. And what's instructive here, and this is where I want you to focus, in this entire rule, what's given out to nursing home nurses, what's followed by hospital discharge planners, there is not one mention in any of this on home-based community care being a priority. It's all about the nursing home eligibility.
Representative Ferrari, you have a question?
Yes, under nursing home eligibility, are you taking into consideration the A beds or the SNF units?
Yes.
Okay, they are, because I know when they go to the A beds and the SNFs, they do go on 30 days or something like that.
We're really going to focus on that at the next meeting and try to get you the data that shows you how many actually stay and how many actually, once they're determined eligible, transition back to a community.
Okay, yeah, I'd like to know the transition rate
Yeah.
out of the skilled and out of the SNFs and out of the
I just want to make sure everybody recognizes transition is when you're in the nursing home and you go back to the community. Diversion is when you are at a hospital or in your community and you are diverted from going into the nursing home by a coordination and service program that keeps you healthy in a community setting. So we're looking at both diversion and transition for you. Representative Meeks and I have talked about, we're going to be doing a visit to the Conway facility by the next meeting. This is, we can go over this quickly, but this is more, I wanted you to see what the census is for the state human development centers for the past few years, what has been the census, and what has been the budget for that facility. And it's not one that I want you to focus on too heavily now, because we'll have more in the, I just want to let you know we're moving to look at that issue. Because some members had asked about it, I thought it was important for you. Health independence account, what have we seen in the last, since we were here last? The number of transactions over the last several months even continue to remain stable. You can see here that the contributions have fluctuated, but again, stable around $2,500 per month. Call center, consistent downward trend. What is on the next slide, though, is on the payment integrity issues. And what we found rather interesting was 4,000 individuals on the Health Independence Program had bad addresses. 4,000. That's 10% of the 45 so thousand, just about, it's 9%. What that tells us is that's very consistent with Blue Cross, the number Blue Cross had given us, at 5 to 10%. So when you do speak to the department about the recommendation, we want to make sure that the vendor at for the Health Independence Program is also doing something when there's a bad address there to identify where these individuals are and whether or not they're in the community, and do they need, notification, and should you still be paying the premiums if they're not around? So 4,000, I thought that was instructive.
Are we going to be in the weeds of this tomorrow?
Yes.
Yes. That's
No, as I said, the payment approved, if you look at the agenda tomorrow, it's got eligibility verification as an item on the agenda. We'll have more time to discuss about it. All right.
Thank you, Mr. Chairman. And this is getting close, I think, to one of the last slides. The payment integrity is one that it's important that you spend some time on this, so this is going to be a lot for the next meeting. But you have the governor's office handles the Office of Medicaid Integrity. We met with Elizabeth Smith and Mark Dixon. They'll be here tomorrow as well. Found them very helpful in terms of identifying issues. And so some of these issues are all going to be discussed tomorrow. Some involving beneficiaries that have been paid after the date of death, and not premiums. You're going to hear more about that tomorrow. And this is recoupments from private carriers. Recoupments are substantial, but you'll hear more about this tomorrow. I wanted to make sure that we got the number for you on the amount of recoupments.
What are those recruitments all for ineligible or for other reasons?
Most are deceased individual payments for deceased individuals after death.
And these are recoupments from the insurance companies back to DHS?
Correct.
Senator Sanders, you recognize the question?
I just want
I just want to provide that clarification. The Office of Medicaid